Yeah, I'm Minneke Steels. I'm a professor of pharmacology at KU Leuven. And since 4 years, I'm chair of the ethics committee in UZ Leuven. Actually, we have a kind of protective role. We should guarantee protection for vulnerable persons when participating in experiments and studies. And the most vulnerable population is our main attention point, actually. But anybody participating in a study and experiment should have this attention. For example, children are very vulnerable, but also patients who are not able to give consent or are unconscious. I think we have to look at to guarantee that everything is in the best possible way to protect participants. Has everything been done to prevent or limit potential risks? Is the principal investigator, the researcher, is he well trained? Has he the right competence to do this kind of experiment? But also the facilities, in which location this experiment or this study will be conducted. Is it in a hospital? Is there sufficient supervision? Do we have sufficient information about studies in animals before it is applied in humans? Is there sufficient information for the participant? Is the informed consent as it should be? Is it understandable? But also one of several things have been added to our role and our in recent years concerning biobanks. We will recognize biobanks, which are actually obligatory collection points for human bodily material. And there has been a lot of jurisdiction about biobanking and biobanking material in recent years, so this has to be implemented in the right way. That is also our task. On the other hand, about GDPR in 2019, which has been implemented in the EU. Also there, how can is the privacy of the participant guaranteed in a proper way towards, for example, external sponsors, commercial sponsors? They should never be able to find out what is the identity of these participants in these commercial studies. So these are some of the elements that we have to look at. But for example, also compassionate use programs at national level, medical needs programs, also for these things they ask our advice. But also master theses of students in biomedical sciences, they also go through our processes. If we look at, for example, the Belgian law in our case, it is specifically stated what kind of members we should minimum have. There is not a limit on the number of members, happily. There should be at least 50% of MDs in an ethics committee, medical doctors. But there should also be nurses. There should be a methodologist who is, certainly if you want to evaluate phase 1 studies, the very early first-in-human studies, clinical pharmacologist. And for the clinical trial regulation, there should be patient representatives in the ethics committee. And for phase 1, of course, also the healthy volunteer representative who should at least have the experience in participating in these kind of phase 1 studies. Also a psychologist, somebody from ethics, human sciences background. So there is, the principle is that you have quite a diverse expertise and competence and quite diverse views and perspectives on a certain study, which is very important. It should be, the more diverse it is, the more input you will get and more balanced a certain opinion will be. And of course, statisticians should be there as well, yeah. All material on all the studies that are on the agenda are available to everybody. That's very important. It's all electronically, which is a good thing in these times, in these COVID times. But I always appoint, together with the coordinator, 2 rapporteurs, and they have the task to provide their comments before the meeting, so we can make a kind of overview of the advices to be projected and to be provided to all the members, and they can add any comment from their perspective. But we have to have these 2 rapporteurs' advices before we start the meeting, so that everybody has this information already to reflect upon. And in this way, we then have a kind of PowerPoint we make with all the input we have got before the meeting. Everybody gets this PowerPoint. This is projected during the Zoom meeting, as we do Zoom now since a few months. And then we discuss it, we go through it, and we ask anybody else other information, other input. Do we agree with this conclusion? And we then together decide whether there is minor remarks, whether we fully agree, which is very rarely the case. There are always some comments, at least, major remarks, or sometimes even a negative advice, if it's really unacceptable. For example, if a protocol is just something like 1 paragraph, you cannot accept it. So it's unacceptable. They have to do their homework again. It is, in most cases, we have a unanimous decision after some discussion. And in some cases, we do an explicit vote. If I feel that there is not a unanimous decision, we do an explicit vote to see to see how many members are for one position or the other. And after that, yes, after the meeting, one of the staff members sends all the remarks to the sponsor, asks for to answer these remarks, and depending on the answers to these remarks, we can decide whether it's acceptable or not acceptable. I think that it is a fresh lay perspective. And that's the reason it's so important that these representatives are lay persons and don't have an education in a healthcare profession. They look at it as patients, being a patient themselves, or having a family member who is a patient. And also about the understandability and the readability of, for example, an informed consent is very important. On the other hand, it is important that a patient perspective is there to decide about what is acceptable to a patient. For example, there are, in most clinical studies, there are some risks and some burdens. And it is quite paternalistic if we, as physicians, decide this is acceptable or this is not acceptable. It is perfectly possible that a patient decides, for me, this risk and this burden is acceptable because I still want to live longer for a few months or so on. For example, I heard once from a patient representative, he said, all these comments of ethics committees about the burden of and the radiological radiation exposure for a third-line therapy where they have a CT scan, but these patients, they are metastasized. He says, I don't care about some radiation exposure. This is completely irrelevant. And I think it's very important to have this perspective from patients. And feasibility, the burden of coming so many times to a hospital and so on, the many hours that are seen. So these things we hear from patients, and that these are very, very valuable elements. We always have, once a year, have a look at all the complaints related to clinical studies that arrive at the ombuds in the hospital. And that is very useful. And one of the things that came out of there is that patients complain that I participated in a study and I nevertheless got a bill for certain things. And that made us think patients assume that if you participate in a study, everything is free. And that's not true. The standard care, which is not part of the study, is not free. So now we make sure that it's very clear and informed consent that the things that are within the study and that are not part of standard of care, they are free. But the standard of care remains something to be paid by Social Security or partly by yourself. On the other hand, I think the length of the informed consents, we are conscious of it as well, but there is such a legal document. It is more written for lawyers than that's the impression we often had, more written for lawyers than it is for patients. And I must say it's like a crusade. We make complaints about it every time, but patients support us there very well. One of the good things recently is that in the new Belgian template, at least their sponsors are obliged to provide a summary. And in this summary, which is often still 4 or 5 pages, and not very short, but everything which is important to the patient should be summarized. We actually spoke to several physicians in our hospital, and from diverse pathologies, neurology, oncology, and we asked them, don't you know some of your patients who would be willing to do that, who are able to do that, not too sick, and who really would like to do it and can verbally express themselves quite well. So they're sufficiently assertive to open their mouth in a meeting like an ethics committee. And in this way, we got several patients referred to us, and also on our website, and we got quite a lot of response to it. So it was kind of a luxury situation for us where we just had to talk to them and then finally decide we couldn't take 20 of them, but we now at the moment had 5 or 6 patient representatives from diverse perspectives, yeah. As I said, we asked several specialists from different clinical fields. That is one point. But up till now, I must say, and in our experience, I have the impression that our patient representatives really try to look at from a specific patient from the field in the domain where they're evaluating the study for. So it is quite broad. I was recently thinking we should still have, for example, the parent of a sick child. That is a perspective where, of course, our pediatricians, which are legally part of the ethics committee, also always are very conscious of what is the burden for a child. Is it worthwhile? This diary every day or 2 times a day is too much for a child, and so on. But maybe a parent would be a good addition still. I think it's something definitely to stay and only to increase. also seen it at the European Medicine Agency, but then for very specific, where you have specific, disease-specific patient representatives. It can be very, very useful. One of the points I'm still struggling with is if you get patient representatives through really professional patient organizations, I'm a bit doubtful whether these are still sufficiently lay in order to give this fresh perspective. And that's certainly something one should be very cautious about. Yeah.